Hello, I'm Ehrin Armstrong. I'm an interventional cardiologist from the Advanced Heart and Vein Center in Denver, Colorado. Thank you very much for joining us for this webinar over the course of the next hour. I'm pleased to welcome you to Advances in Endovascular Treatment of Chronic Limb-Threatening Ischemia, Insights from the LIFE-BTK Trial. This CME event is presented by the VIVA Foundation, a nonprofit organization dedicated to advancing the field of vascular medicine and intervention through education, research, advocacy, and philanthropy. In addition to our educational conferences and webinar, the foundation also convenes the Vascular Leaders Forum and also supports important endovascular research trials. As you're probably aware, this webinar has been accredited for one AMA PRA Category 1 credit, and attendees will receive an email the day after the program with instructions to claim that credit. Over the next hour, we're going to hear from a multidisciplinary panel of experts, including 3 of the study PIs from the LIFE-BTK trial, as well as a representative from the FDA, who are going to be offering a comprehensive view of the LIFE-BTK results and their potential impact. I'm pleased to introduce our multidisciplinary panel of speakers and panelists joining us tonight. From the Specialty of Vascular Surgery, we have Dr. Niten Singh from Harborview Medical Center and the University of Washington in Seattle, Washington. He is also my co-moderator tonight. Dr. Brian DeRubertis from the Cornell Medical Center will also be presenting and on the panel, as well as Dr. Ramon Varcoe from Australia and Dr. Elizabeth Genovese from the University of Pennsylvania. Representing the field of interventional cardiology, in addition to myself, is Dr. Sahil Parikh from the Columbia University Irving Medical Center. From vascular medicine, we have Dr. Raghu Kolluri from Ohio Health Riverside Methodist Hospital, who's also currently the president of the VIVA Foundation board. From interventional radiology, we have Dr. Mahmood Razavi from St. Joseph Heart and Vascular Center in Orange, California. And then finally, from the FDA, we have Dr. Misti Malone representing the regulatory perspective. Tonight, my co-moderator, Dr. Niten Singh, will also be monitoring the live Q&A, and we encourage you to participate by submitting questions via the chat. So with that introduction, we are now going to hear 3 presentations from the LIFE-BTK primary investigators, including Drs. Brian DeRubertis, Dr. Sahil Parikh, and Dr. Ramon Varcoe. They will be giving us an overview of the trial results, the potential impact of those results on future BTK trials, as well as what is next emerging for bioresorbable scaffold technologies. After that, we will follow up with a 10-minute panel discussion.
Good evening. It's a real pleasure for me to be able to discuss the results of the LIFE-BTK 12-month randomized controlled trial. So in order to effectively treat BTK disease, we have to deal with both mechanical issues of residual plaque or dissections, as well as the issue of restenosis. And the Abbott Esprit BTK scaffold is designed to do just this, by providing a scaffold to deal with those dissections or other issues that affect the mechanical properties of the vessel after treatment, and then to elute a drug over time to prevent restenosis. And this is done in the case of the Esprit BTK scaffold in a temporary fashion, as this device resorbs over time, thereby preventing some of the negative ramifications of permanent implants. In order to do this, the device is comprised of a PLLA resorbable scaffold with a struct thickness that is about 99 micrometers, similar to the Zion stent or other coronary stents, delivering everolimus at a dose of about 100 micrograms per centimeter squared. So very similar to some of the coronary devices used in other circulations. This device obviously is implanted, deals with mechanical issues, elutes drug to prevent restenosis, and then over the course of about a year to 2 years, we have full resolution of the reabsorption of the device, thereby allowing for regain of healthy vascular function, essentially. This device was evaluated in the LIFE-BTK the LIFE-BTK randomized multi-center trial, in which 261 patients were randomized in a 2-to-1 fashion between the Esprit BTK scaffold and the NPTA as a standard of care arm. We evaluated the data at 12 months, and this was reported in fall. We looked at the primary safety endpoint at 6 months and primary efficacy endpoint at 1 year, as well as a couple of important powered secondary endpoints. So in terms of the primary efficacy endpoint, this was a composite of limb salvage and primary patency, defined as freedom from above ankle amputation in the index limb, 100% total occlusion of the target vessel, binary restenosis of the target lesion, and CD-TLR at 12 months. For the primary safety endpoint seen at evaluated at 6 months, this included the standard Mail-POD endpoint of above ankle amputation or major intervention in the index limb, as well as postoperative or perioperative death up to 30 days. Now, importantly, we added in 2 secondary endpoints that were powered. One was binary restenosis of the target lesion at 1 year, a duplex-derived endpoint, and we really wanted to evaluate this component of the primary efficacy composite endpoint separate from the other features to see what effect this somewhat newer endpoint or addition to our endpoint, how this affected or impacted our overall endpoint. The inclusion criteria is listed here. Essentially, we treated up to 2 lesions, 2 de novo restenotic lesion in the infrapopliteal vessels, limiting our treatment to the upper 2/3 of the lower leg with a total scaffold length of up to 170 millimeters. And these patients were all Rutherford 4 or 5 category. In this trial, we really wanted to represent patients in the trial that were similar to the patients that we treat every day. So this slide here shows our effort, the success with which we were able to do this. In the gray bars are Medicare data or CMS data throughout the United States, both in terms of gender as well as race and ethnicities. And you can see that our distribution of LIFE-BTK sites in the US and even OUS really allowed us to achieve this very similar demographics that we have in our overall patient population here in the US. So we think we achieved this goal. This shows the key baseline and history risk factors. You can see that hypertension, hyperlipidemia, and diabetes were almost ubiquitous. Patients were relatively equally split between Rutherford 4 and 5, and some other factors were also quite common, such as tobacco use and prior coronary interventions. Target baseline lesion characteristics, or target lesion baseline characteristics, are shown here, including the distribution, which I won't get into too much, but I do want to point out the mean lesion length of approximately 44 millimeters, and this was similar in both arms. This is the real important slide here, the primary efficacy endpoint at 1 year on an ITT basis, and you can see that the Esprit scaffold achieved a 74.2% composite endpoint of limb salvage and primary patency compared to 47.9% for PTA. And this is a very statistically significant 30.8% difference between these 2 arms. So really quite unheard of in these below knee trials. In looking at the landmark landmark analysis of the primary efficacy endpoint, we see approximately where these curves tend to diverge. And you really see that we had very similar results out to 6 months, and that's where we really got a displaying of the curves beyond 6 months. Looking at the powered secondary endpoints just briefly, this shows binary restenosis, 25% difference between the PTA arm and the Esprit scaffold. So it shows that this was an important driver of our composite endpoint. But even with this ultrasound-derived analysis or endpoint removed, looking at just the rest of the composite primary efficacy endpoint factors, we still had a 14.2% difference, which is highly statistically significant, 82 compared to 70.4. Primary safety endpoint was same out to 6 months in both arms. And we looked at subgroup analysis, sex, race, region, etc. These all favored the Esprit scaffold over PTA. So these results were, of course, simultaneously presented in the fall and published in the New England Journal of Medicine, and this is available as of this January in print form. So to conclude, the BTK circulation presents some specific challenges to successful intervention. The LIFE-BTK trial did demonstrate the potential advantages of a combination device of scaffolding and drug elution that resorbs over time, and if approved, this therapy could usher interventionalists into a new era of BTK therapy. Thank you.
Good evening. It's my pleasure to be here. My name is Sahil Parikh from Columbia University in New York. And I'm here to talk in the next 5 minutes about implications of a LIFE-BTK trial for future BTK trials, specifically looking at endpoints, trial designs, and a few other key features. These are my disclosures. I think we'll try to quickly run into some of the important topics, including the primary endpoints and the use of a composite and the observation duration of this trial. We'll look at some of the powered secondary endpoints, which I think will be relevant for future trials. And then also some of the descriptive endpoints that may answer some of the clinical questions that people really are interested in and should be included, I think, in future trials. We'll get to a little bit about the burning questions about duplex ultrasonography versus angiography for endpoint adjudication. And then some of the inclusion criteria, specifically the Rutherford-Becker classifications for who should be in and out of a CLTI trial. And then we'll talk about how we achieve diversity in the trial. I think everybody recognizes that LIFE-BTK was randomized 2-to-1. Importantly, we looked at patients for their primary safety endpoint at 6 months and the primary efficacy endpoint not at 6, but rather at 12 months using a composite endpoint. These endpoints are noted here. The primary efficacy endpoint was a composite of freedom from above ankle amputation in the index limb, total occlusion of the target vessel, binary restenosis, which was a new sort of addition, and a clinically driven TLR. The safety endpoint is a fairly standard freedom from major adverse limb events plus perioperative death. The secondary endpoints, which are important and were powered in this trial, looked at the binary restenosis, which was the new addition to the composite, as well as freedom from above ankle amputation, total occlusion, and clinically driven TLR, the so-called old primary endpoint. And this allows comparison, if that's allowed, between trials. Again, you've seen the data already that the primary endpoint difference was an absolute difference of approximately 30% in the intention to treat analysis. And then if you look at 393 days, again, using a different Kaplan-Meier approach, it's a similar difference. And again, if you look at the landmark analysis, which I think is important, you see that the separation really doesn't begin until 6 months. And that's really why I think future trials are going to look for both clinical and biological effect, not just at the 6-month endpoint that has previously been proposed, but really at the 1-year time point where you see separation of the curves. Again, the secondary endpoints are important. The powered secondary endpoint, again, you see separation of the curves really not beginning until 6 months' time, to wit, the reason to observe patients for longer. And again, when you're looking at the second powered endpoint, or rather secondary endpoint, the one which subtracts out the binary restenosis component, you can still see that there's a statistically significant difference, but that the difference is a little bit smaller. It's about a 12% delta. And this is the endpoint that's probably comparable to other similar trials. And I think future trials will probably be parsed out like this in order to allow comparisons of biological efficacy. What about the descriptive endpoints? I think the one that people are really interested in is, did the device prevent clinically derived TLRs or TVRs? And you can see in the descriptive endpoints in the supplement of the appendix that that was in fact the case. And I think future trials will also need to be very careful about leaving these descriptive endpoints in. You can see a whole host of them that are in the 83-page supplement with the New England Journal paper. What about duplex ultrasound? We spent a lot of time looking at whether duplex would be sufficient to assess binary restenosis. This is a flow diagram of how the duplex was assessed. But importantly, here's the definition. Using a peak systolic velocity ratio of greater than 2, along with the associated factors of a focal increase in the absolute PSV, spectral broadening, post-stenotic turbulence, and review of the B-mode images for plaque burden. In toto, these composite assessments done by the core laboratory allowed us to very accurately gauge the freedom from restenosis, and this is based on prior publications in the literature. I think duplex is clearly more convenient and probably is the way to go for future assessment. What about inclusion? We had a very sick population with lots of different clinical comorbidities, but about half were at Rutherford-Becker's 4 and 5, and I think it remains unclear how many patients without wounds we'd like to have in future trials. And finally, with respect to diversity, we were able to achieve diversity similar to the United States population, and I think if we can do it, so can everybody else. So with that, I'd like to close and say these are a few nuggets that we can maybe talk about in the discussion about how LIFE-BTK might predict what the future of below-knee trials looks like. Thanks very much.
My name is Ramon Varcoe from Sydney, Australia. These are my disclosures. There's been an explosion of interest in bioresorbable drug-eluting scaffolds since the publication of the LIFE-BTK trial in the New England Journal of Medicine in January. This trial, of course, showed a clear superiority of drug-eluting scaffolds over angioplasty, creating a lot of excitement. What I'm going to do today is talk about the next generation of scaffolds that are being investigated at various stages of development. The first is the motive scaffold from Riva Medical, and this one has been CE marked in Europe for quite some time. This is a PLLA scaffold, but it also has an iodine compound on the structure, which gives it this radio opacity. As you can see on the panel on the left here, it looks very much like a regular metallic stent. And I'm going to quickly go over some of the early results presented by Michel Boziers in Link earlier this year. So the study was a first-in-human study, and you can see here from the demographics that it was a real-world series of patients, with almost 2/3 of patients having diabetes, and about 43% of them suffering from renal insufficiency. Most of these patients with Rutherford 5, so they had wounds, and a significant proportion had outflow lesions as well. The mean lesion length was just under 30 millimeters, so pretty short. And again, emphasizing the real-world nature of the lesions, almost 50% had calcification. Here you see the 12-month results. You see 99% technical success rates. The primary patency was 90% at 6 months and then 88.3% at 12 months. Very encouraging. It's also nice to see improvement in Rutherford scores progressively and incrementally over the 12-month period. Here's a case presented by Dr. Boziers, a TP trunk lesion treated with a single motive scaffold with a very nice angiographic result at the end. The next generation scaffold is the R3 vascular scaffold, which is made of an ultra-high molecular weight PLLA, which gives it some really interesting properties. The first is you can make it up to any length you like, so very long lengths can be created, and it also has super elastic crush-resistant properties. Here's a case presented by Marianne Brodman, another TP trunk lesion with an excellent angiographic result from a single scaffold at the end. Its very thin strut thickness, 98 millimeters, is very good for infrapopliteal arteries, and it elutes sirolimus with a very sustained elution profile, which we think may be promising in this region. Here you can see in the dark blue bars at the bottom, the molecular weight loss over time. You can see that most of it's gone by 18 months, but that the radial force in the light blue bars is maintained out to around the time when 75% of the scaffold has been reabsorbed. In the first-in-human trial, most of the patients were enrolled in Austria, but the rest were a combination of Italy and also Canada. You see that in the 31 lesions treated, they deployed 56 scaffold in all of the tibial arteries. These were fairly simple lesions, as demonstrated by the fact that very few had moderate to severe calcification. This is the 6-month primary endpoint. The safety endpoint of freedom from major adverse limb events and perioperative death was 100%. And the primary efficacy endpoint of freedom from binary stenosis and total vessel occlusion was 93%. You see here on the right, the red bar represents the stenosis before treatment, the grey bar after treatment, and then very little late loss at 6 months, only 0.67 millimeters. We see an improvement of Rutherford category, particularly in the Rutherford 5 group, with wound healing progressively over the 12-month period of follow-up. The next scaffold I'm going to talk about is the ephemeral vascular scaffold system. This is a series of balloon expandable PLLA and copolymer scaffolds. These are short independent scaffolds that move independently as the SFA bends and stretches. Here you see it on the deployment balloon. There's very little space between the scaffolds initially, but when it's deployed, those spaces, those interscaffold spaces expand, allowing the individual scaffolds to move freely. This is a porcine experiment here. You see on the top the scaffold with very little intimal hyperplasia at all at 2 years, compared to a self-expanding stent in the bottom panels with a lot of intimal hyperplasia. And this is from the same study looking at OCT here. You see complete endothelialization of the scaffold at 30 days and progressive resorption of the scaffold over 1 to 2 years. This is the intimal hyperplasia. The grey bar represents the scaffold. The red bar represents a self-expanding stent, and you can see there's a lot less intimal hyperplasia with these scaffolds. They're currently enrolling the ephemeral 1 clinical trial, which targets 100 patients in Rutherford categories 2 to 4, and they're midway through this trial at the moment. So in conclusion, bioresorbable scaffolds have properties which give them inherent advantages over permanent implants. And we've seen early observational data and now a large-scale RCT, which shows considerable promise in infrapopliteal arteries. This has led to several next-generation scaffolds being trialled both above and below the knee. Thank you for your attention.
Great. Well, thank you for those three initial outstanding presentations. I think they provide a really great overview of the LIFE-BTK style trial and the Esprit scaffold. We have about 10 minutes of discussion before the next group of talks. I'm going to kick things off by asking Sahil a question. I think we talked a lot about the trial results, but we do have some questions from the audience about the actual scaffold itself. Could you just provide a brief overview of what the polymer is and the elution timeframe and resorption of the scaffold?
Yeah, so the polymer is polylactic acid, or PLLA. It's commonly used in a number of the devices, as you've seen from Ramon's talk, and the properties of the elution kinetics are similar to that which are seen by most contemporary coronary drug-eluting stents. In other words, it has a first-order release profile where there's early release that's relatively rapid and sustained out to anywhere from 90 to 180 days, with drug residence in the tissue usually out to several months. And that characteristic profile is very typical of most drug-eluting stents that are used in coronary applications today.
Great. I think another question that comes up with these trials is, part of obviously this is randomized against balloon angioplasty. And Brian, maybe you could give us some insight in this trial. Was there any type of special vessel preparation that was allowed, such as atherectomy or other specialty balloons, or was this pure angioplasty as opposed to the use of a bioresorbable scaffold?
Yeah, that's a great question, Ehrin. And we did have some parts of the protocol that ruled out extremely calcified lesions that couldn't be dilated with a standard angioplasty balloon or a non-compliant angioplasty balloon, to avoid having lesions that were not adequately prepped prior to scaffold implantation, because appropriate implantation and appropriate implantation technique is really a key to good results with this device. Some of the other devices that we could have included in the trial for vessel prep would include atherectomy, perhaps even shockwave or lithotripsy devices. We felt that would be looking at too many variables and would not allow us to really look at the scaffold, the results of the scaffold by itself. And so we did not allow atherectomy or some of these other more aggressive forms of vessel prep. Part of the rationale for that too, though, is that despite the use of atherectomy, which is fairly common in the U.S., the bulk of cases are really done with angioplasty alone as a standard of care. And in 2024, I would say that is still the standard of care for tibial interventions is angioplasty. We use that in the majority of our cases. Even someone like myself who uses a fair amount of atherectomy as vessel prep. In the tibials, the majority of my lesions I'm treating are balloon angioplasty. So the vessel prep in this case was balloon angioplasty rather than some of these other devices.
Hey, Ehrin, I
Great,
got a
thanks.
couple of questions from the audience as well. From Gary Ansel, he asked, what percentage of patients can be adequately pre-dilated to be included in the trial?
Yeah, so Niten, there was only, 5 bailout stents in the study. There were fewer patients in the angioplasty group that had completion of the intervention with less than 30% diameter stenosis. The data are buried in the supplement, but it's all there. Most of the patients that were pretty carefully selected, and as Brian pointed out, there was really very little in the way of severe calcification that might have been an impediment for appropriate dilatation. Randomization occurred after guide wire crossing, to be fair to both groups, and certainly I think that's an important distinction.
There's another good one for you guys. What kind of vessel features should be considered to avoid scaffold implantation? Do you guys have any experience, or which ones do you avoid?
Yeah, I think the main thing I would point out is that in the context of a clinical trial where you're evaluating the efficacy of a device, we're going to have some differences than we see in what we typically would call the real world lesions, right? And so the mean lesion length was 45 millimeters roughly in this trial in both arms, and we don't know for sure how well this scaffold will perform in much longer lesions than that. The other thing we did is limited the scaffold to the upper 2/3 of the lower leg, and obviously as we move down toward the ankle, the compressive and constrictive forces of the fascial compartments become more severe, more substantial, and we thought it was best to avoid putting the scaffold down in these areas that could suffer from some crush issues. And I think that is another area where we don't know how the scaffold performs. We don't know if lesions in that area are really the right, are best treated with this type of scaffold. They may be, but I think there's a lot of uncertainty there. And so many of us feel that most likely this device would be used in the more proximal 2/3 or so of the lower leg. And perhaps in the future, we'll have some other modalities like DCB for some of those more distal and perhaps smaller vessels as well. Finally, calcification I mentioned as well. Severe calcification was something that would exclude one from this trial, although the inability to dilate a lesion was almost unheard of in this trial. There really weren't a lot of those issues.
I have another interesting question from the audience. One is about, how representative was this as a critical chronic limb-threatening ischemia population? I think if you look at the ABI and the TBI, they weren't that low for patients with non-healing wounds, and they're relatively short lesions. Did the patients who had rest pain, did they really have rest pain, and were the wounds related to vascular etiologies?
We don't want to steal Raghu's thunder. He's going to go through some of those in the next talk, Ehrin, but I think there's been very few, if any, data in a large RCT with a core laboratory for wound evaluation heretofore, and I think we learned a lot about this patient population. To put it in perspective, over 600 patients were consented and 261 were randomized. So there were a number of anatomic exclusions, and there was a large number of patients screened in the outpatient setting that was distilled down to the 261 enrolled. So this is a subgroup of what we see in clinical practice. Notwithstanding that, however, these were all, clinical CLTI patients called from 50 sites globally with very outstanding investigators and great teams. So I don't want to minimize their contribution to the space.
Yeah, and I'll just add to that. The truth is, if you look at the demographics of this patient population, it was a very sick patient population, very much like we see in our CLTI patients. And in terms of the ABIs, with the other factor that we found here is that many of these patients had non-compressible suprasystolic ABIs, and so until we have a trial that includes something that maybe is a little more advanced than ABIs, such as plantar acceleration times, I think we'll probably have trouble getting objective quantification of the severity of the hemodynamic compromise.
I think it's also important to point out that although the mean lesion length turned out to be 4.5 centimeters or so, that lesions up to 17 centimeters were allowed in this study. So there is that subgroup of patients with long lesions that would, for those people who think that, these are all short lesions and the outcomes, would be expected. So I think it's important to discuss that.
Yeah, and then Liz, I have a question for you too. I think, as a practicing vascular surgeon involved in a lot of trials as well, what are your thoughts about how this trial, the endpoint was different than prior trials? There's been a lot of failures in the below knee space, but we have a success here from a trial perspective. But obviously a lot of these endpoints and the primary endpoint were driven by binary restenosis as opposed to occlusion or target lesion revascularization. Do you think that impacts how you utilize this device clinically, or do you think that this is the new standard for below the knee trials?
I think it was an interesting contribution to the study because even if you take the binary restenosis, obviously you still have a clinically and statistically significant difference in outcomes with a device compared to angioplasty alone. But interesting with the binary restenosis, particularly as you see the curves diverge at that's the mark. That binary restenosis kind of indicates to me a little bit of how we're going to affect the pressure to the foot. Often we worry that with endovascular and wound healing, we may not be getting quite as a robust fusion pressure to a wound on the foot compared to maybe an open bypass. And so for me, this is indicating that, we're still maintaining as much fusion pressure to the foot. So to me, that's a pretty clinical endpoint. And so it's reassuring that I see a difference in the outcomes of the procedure with the bioabsorbable stent compared to not only binary restenosis in there, but also with it out of the have, particularly at that 6-month mark, you're healing a more robust wound or potentially even healing a TMA, you may need that kind of as much perfusion to the foot as possible all 6-7 month period. So I think it's a clinically important one to me as someone who can offer both an endovascular and a surgical option to the patient.
Yeah, no, I think those are very important points as we look at kind of some of the other clinical related outcomes in these patients. And I think that's actually a good segue to the next group of 3 talks. We're going to have 3 talks followed by some additional panel discussion. So our next 3 talks are going to be presented by Dr. Raghu Kolluri, who's going to discuss wound outcomes in the LIFE-BTK study, followed by Dr. Mahmood Razavi discussing the potential impact of the LIFE-BTK results on practice. And then finally, Dr. Misti Malone of the FDA will discuss the impact of these clinical outcomes versus measurements of device patency for subsequent approval in future studies.
Hi, I'm Raghu Kolluri. I'm going to talk about the wound outcomes in this LIFE-BTK trial. These are my disclosures. For long, peripheral artery disease trials or critical limb ischemia trials have focused on patency of the treated segment, whether as a measure of binary restenosis or angiographic success or duplex success of keeping the vessel open. Primary endpoints have been composite, including limb salvage, CDTLR, and amputations. Sometimes survival measures were also included. And primary safety endpoints such as freedom from major adverse events, freedom from TLR are also included. Wound care and wound healing to date has not been a major player in the outcome measures of peripheral artery disease as an endpoint until LIFE-BTK. So we're going to talk about that. There are numerous contemporary technologies to image wounds, and these are just a few examples. And in LIFE-BTK, e-care device was used. Basically, what we do is we first assess whether the wound is ischemic or not by a long shot, such as this one below the knee picture, to assess if there is any issue such as venous insufficiency, etc., or maybe Charcot's joint, for example. This is a clear-cut ischemic ulceration, but when you look at this wound here, it's definitely venous insufficiency associated with it, in addition to the ischemia as based on the clinical examination and other non-invasive testing, I suppose. And finally, you see a neurotrophic ulcer, which will not heal unless it's offloaded in addition to the revascularization. So all of these were carefully addressed in this study. When you look at the total number of wounds enrolled, it's 184, the largest cohort in the CLI space to date. And when you look at the Esprit versus angioplasty, they're pretty evenly distributed in terms of Rutherford 4 or 5 and right to left, etc. And remarkably, 90+% of the wounds were analyzable by the core lab. And as you can see, the distribution is noted there. Great elements that we were able to come up with the locations so that we could work on the angiosomal concept later on, etc. For example, here you see that about 10% were above the ankle, and rest all distal to the ankle on the dorsal surface, toe, plantar surface, or heel. And the other piece that is super important is to know the etiology of these wounds. Are these purely ischemic, which are about 71% in the Esprit and 76% in the PTA, while mixed etiology accounted for the rest of the 28% and the 23%. As you can see, this was all based on that initial wound etiology picture. So the top line items, wound healing, occurred in up to 80% of patients in the Esprit group and 76% with no statistical significance at 1 year, which is pretty high compared to what one would expect with CLI wounds, but it was there. And when you look at that at the number of subjects level, there was no difference between PTA and Esprit there too. When you looked at the index healed wounds, again over the year, there was no significant difference in the overall cohort between Esprit and PTA. And when we looked at ischemic wounds versus mixed etiology wounds, those 23% of the wounds, again, there was no significant difference between the two, although there was a little delayed healing, as you see here in the PTA and the mixed etiology wounds. Average time to heal also was not significantly different in any of these groups. Average wound area was also not different between any of these groups. Recurrence was also no different between any of these groups. But when you look at the primary efficacy endpoint and look at the forest plot here, the arterial insufficiency only was clearly favoring the primary endpoint, which was ankle, above the ankle amputation and the index limb total occlusion, binary stenosis, and CDTLR freedom at 12 months. So, in conclusion, wound care is complex. There was no significant difference between the two when you look at them individually, but when you look at the primary endpoint itself, ischemic wounds clearly made a difference in the outcome. It's a pragmatic trial. Wounds are complex, and it's a difficult thing to prescribe wound care to participating PIs. The success depends on individual cooperation to a great extent too, and both arm patients received high quality of care. Most importantly, the Esprit did not result in disruption of wound healing, which was one of a biggest concern before all of these drug-eluting technologies came out. Thank you.
Thank you for the invitation. The topic is impact of LIFE-BTK results on practice. These are my disclosures. The realities of CLTI patients' routine practice is that most of these patients have multiple associated or independent medical comorbidities. They make repeated visits to physician offices and wound care facilities. They have frequent hospitalizations and generally suffer from a poor quality of life. For those reasons, time away from hospital and other healthcare facilities is important to them. Now, realities of revascularization in routine practice is that many of these patients are either too frail for bypass or don't have suitable veins or conduits for bypass. Bypass itself, even when they do have suitable conduits, is associated with some morbidity and requires prolonged recovery in this patient population, as we talked about, who really values time away from hospital and SNFs and care facilities. Therefore, endovascular approach is preferred by both patients and physicians. And that's why endovascular approach to this patient population is fast becoming the first therapeutic revascularization modality of choice. Endovascular landscape, unfortunately, has not changed in a long time. And durable and efficient options have eluded us. And by efficient, I mean when we angioplasty, even atherectomy, a vessel below the knee, the flow through that is far less efficient than a bypass or a normal vessel. And that's important. Now that we have mechanisms to actually measure the real-time flow or impact at the foot level, we have noticed, and obviously with IVIS also, that what we do in these patients really not that efficient and of course not durable. As has been alluded to by other speakers, multiple failed attempts or stopped trials. These were the randomized drug-coated balloon. This was a randomized nitinol DES. They've all failed or stopped. Despite suboptimal patency, balloon angioplasty unfortunately remains the mainstay of below the knee interventions for a long time. It hasn't changed. Just to elucidate the point, this is a 73-year-old patient with a non-healing wound. As you can see, there's perineal disease. The other two vessels are out. The perineal artery is balloon dilated, and the angiogram looks okay, the flow looks okay, but the IVUS doesn't. This is not a very efficient lumen, and therefore the posterior tibial artery was recanalized and opened up. But by the time we opened up the posterior tibial, the perineal is gone. So is that a recoil? There's a thrombus, there's a dissection there. So we opened that up again, and of course now it looks, two vessel runoff, it looks good. Unfortunately, wait a few minutes, and you can see the posterior tibial is going out. We open up the posterior tibial, you see now the perineal is going out, and it's become very clear that it's plaque recoil that's happening in both of these vessels. This is what we're used to, unfortunately. Nobody hangs around for 20 minutes after angioplasty to see what the results are. If they did, you'd see an early failure results. The angioplasty in BTK has bimodal mechanism of failure. The role of recoil and dissection in that failure is much better recognized now. DCBs, unfortunately, don't address that early failure. They may, deliver the drug, even if they do, but they can't handle recoil and dissection. Coronary DES could be a potential solution, but none are on label in the US. Disease extent and reimbursement policies make their use impractical, and we leave a permanent metallic device behind that most of us don't like to do that. Drug-eluting resorbable scaffolds have the advantage that elucidated in this case. Here's a very similar patient as we showed. This was done in January of 2001. This is post-treatment using a spree. Now you can see that that is an efficient lumen by IVUS or by measurements at the level of the foot. And this is exactly 3 years and 2 days later. This is not what we're used to in this patient population, as the previous case showed. So how does the availability and an on-label DRS impact practice? Well, we know the DRSs restore blood flow in an efficient manner. They maintain vascular integrity early on and reduce neonatal hyperplasia late. Therefore, they address both failure modes of below-the-knee intervention. They likely preserve future revascularization options because they are resorbable. Therefore, they're a better option for patients with CLTI and better option for treating physicians. Thank you.
Hi, good evening. My name is Misti Malone, and I'm the Assistant Director of the Office of Cardiovascular Devices at FDA, and I will share our perspectives on endpoints for CLTI trials for our regulatory decision-making. I have no disclosures. Although the space is still immature, we've learned many lessons from the previous and ongoing CLTI trials. We currently recommend randomized controlled trials to assess the comparative benefits and risk for devices, unless the patient population has no other surgical options. The trial should be well designed, operated, and monitored with diverse patient enrollment, as well as there are well-known socioeconomic disparities in CLTI patients. The procedure should mirror practice, but be as standardized as much as possible. We recognize that these patients will have additional procedures such as minor amputations, so it's vital to include objective assessments with consistent definitions and to consistently capture data and images, particularly for reinterventions and wound healing, to minimize potential bias and confounders. To evaluate the device benefits, you should consider what benefit and the subject device, your device, is adding to the procedure and how the patient has improved. Is the intention to open the vessel, as with angioplasty and stents, or to clear plaque and thrombus as an adjunctive therapy prior to angioplasty and stenting? And to assess these, we measure short-term and long-term patency, target lesion revascularization, and/or changes in persistent stenosis during the procedure. And these would be the primary effectiveness endpoint. Secondary endpoints typically include clinical outcomes to demonstrate how the patient has improved. Did walking and activity improve? Did the wound heal? And were fewer repeat procedures and amputations? And these endpoints may include quality of life or patient-reported outcome measures, wound assessment, target lesion revascularization again, amputation rates, and mortality. And the figure on the left is from an article in 2021 examining endpoints in 49 CLTI studies. It's a nice summary of the recommended measurements for clinical outcomes and perfusion assessments, and it also discusses places where there continue to be gaps. Focusing on stents and drug-coated balloons, we generally recommend the primary endpoints displayed on this slide, recognizing that you may identify other primary endpoints based on the specific benefits and risks of your device. And for general CLTI indications, the primary effectiveness endpoint has been a composite of limb salvage and primary patency, though endpoint definitions may differ among trials. And we'll also consider hierarchical endpoints as an option for these trials. For studies evaluating patients with no surgical option, the primary composite endpoint for safety and effectiveness has been amputation-free survival. And the primary endpoints may be evaluated at 6 months or 1 year, and if 6 months is used, we do expect a substantial number of patients to have 1 year data at the time that you submit your marketing application. Secondary endpoints include wound healing, changes in quality of life, and other outcomes. And we are particularly interested in wound healing as it's important to both clinicians and patients. However, there's a lack of rigorous and uniform methods to collect and assess wound care data. As such, it's vital to gather complete photographical documentation and characterization, and we strongly recommend a core lab for consistent, objective wound assessments. Although my focus of this talk is on effectiveness endpoints, here are some typical safety endpoints for these studies. It's typically evaluated as freedom of major adverse limb events and perioperative death through 30 days. A sampling of secondary endpoints are included here in order to capture outcomes important to patients, clinicians, and regulators. And we recommend collecting as much information as possible to better understand the benefits and risks associated with your device. Because in our experience, the data in this patient population can have high missingness, which was particularly challenging during the pandemic, and this can lead to challenges with interpretation of the data. And for example, it is important to identify the types of follow-up amputations. We expect some amputations, so it's helpful to understand if they are planned or unplanned and provide thorough narratives. In conclusion, we believe that it's important to standardize and harmonize definitions and treatment strategies in CLTI trials, and we greatly appreciate any collaboration in this regard, especially what VIVA has provided previously and in the future. And we would like to stress the importance of evaluating treatment strategies in patients with CLTI, prospective plans to obtain high-quality interpretable data, and given the limited data currently available, there remains ample opportunity for learning in this area, particularly as early studies will inform later studies, which in turn will lead to improvements in study design and clinical outcomes. Thank you.
Thanks very much, everyone, for that outstanding group of 3 other presentations. We have about 15 more minutes of panel discussion time now. I think one thing that was brought up during those talks, too, is the fact that there have been other trials in the tibial space that have not shown benefit. These were, of course, primarily with paclitaxel related devices. So, one question I have for the panel is, obviously, we have a positive trial here. Is it because we were using a different endpoint, a different drug, or because it's a bioresorbable scaffold, or is it some combination of those?
If I could comment on that, I personally don't think it's a drug. There may be differences in the drug, but I don't think that's the reason for failure. The coronary drug-eluting stents using paclitaxel early on, even below the knee, those also showed very good results. Now, combination, of course, endpoints having restenosis in there was a contributor to the difference, but we know, as Dr. DeRubertis mentioned earlier, that even without that endpoint, this would have been a positive study. I think it has to do with the fact that there's a scaffold. Now, there are multiple, not only randomized studies, but meta-analyses using coronary drug-eluting stents that once you put the drug-eluting scaffold, the outcomes are improved. So I think, while it's a combination of things, but it's, in my opinion, primarily it has to do with the fact it's a drug-eluting scaffold.
Ehrin, if I was going to ask Dr. Malone and Dr. Kolluri, when you think about wound, this is a very nice example of a study looking at wound results. But you yourself said, Raghu, that wounds are very subjective to heal in trials, and being part of a trial is probably going to be, showing that you're going to have better wound care. So when that's a key secondary endpoint that Dr. Malone talked about too. How do we standardize this to almost a real world type practice or scenario?
Yeah, that's a fantastic question and a huge limitation in these trials, right, Niten? Because the practice patterns differ so much. Maybe in your side you take care of all the wounds, but in another side maybe the podiatrist maybe send the wound patient, and then to keep that referral pattern going, the patient goes back to the wound center or to the podiatrist. Whatever that may be, it is incredibly difficult to standardize wound care. But when we talk about pure ischemic wounds, honestly, if the inflow is the most important aspect, I hope you agree with that. And for those mixed etiologies, if it's a neuroischemic ulceration, if it's a Charcot's joint, if it's gout or trauma, whatever that is, that I've seen all sorts of wounds enroll into CLTI trials. Unless those are managed, inflow is not just going to be enough. So I think if we can sort out the ischemic versus non-ischemic, and select high quality sites, that's the closest we can get. Despite this trial being so aggressive about getting every wound image possible, there were still difficulties. The sponsor, the core lab, the sites were tight in terms of getting the wound images, but there were times where the core lab had to call the site and have the patient grab the patient before they left the wound center to get a better picture. So these are all difficulties that we faced, and we're working on this manuscript to describe all those details.
One of the things I'll just throw in there as well is that it's definitely an important endpoint. It's a clinical endpoint that matters the most: wound healing and limb salvage, right? But that is such a gross outcome measure that although it's important, although from both a regulatory and a clinical standpoint, it's an important metric to follow. I think it always has to be a secondary endpoint. We have to accept that in the context of the clinical trial, because it's too difficult to make that a primary endpoint for so many reasons, right? And one of the things that although we talk about standardizing wound care and that sort of thing, that would help us maybe tease out some of the variables or eliminate some of the variables in the issue of wound healing, but that's just not practical. What maybe is more practical is designing trials going forward that had a panel that would pre-approve enrollment based on the wound, because even though we tried very hard to make these become to enroll only arterial ischemic ulcers, there were a significant number of mixed venous and arterial ulcers, and some that frankly weren't arterial in nature that would not be expected to benefit from revascularization as much as some purely ischemic ones. And so that is something we learned from this trial. We learned about wound recurrence from this trial. We learned about the difference in the types of wounds and how hard it is to get pure arterial ischemic ulcers. So, the core lab did a great job of helping us tease that out, and I think future trials will do even more to tease out those issues.
One other thing, if I may add, is the Rutherford sixes are even more difficult to manage in terms of digital imaging of the imaging devices we have, because the very large ones, it would be difficult to assess the area, the depth, and those type of things. So Rutherford fives are a lot easier. So it's not that easy. We've seen pictures of casts before we grab them to get proper pictures. All sorts of different things which had to be repeated. So it to get clean data. So this trial really taught us a lot.
And at FDA, I feel like we've learned a lot also working with many companies on these particular trial designs. Everything you've said here is absolutely correct. And I believe Abbott's proactive engagement here in order to standardize as much as possible to capture good images. We've seen challenges with images as, for example, if there is a toe wound and the patient has a minor amputation, is that a failure, or is because the amputation heals well, it's fine? And so being able to understand the narratives helps provide that what we call the totality of evidence. We look at everything, not just one piece of the picture. And we've also seen in other trials where wounds will get bigger before they heal. And so again, is that a failure at that time point, or is that what we want? So I think wounds have been challenging in that regard. And I've commended companies for the efforts that they're doing to be able to capture as much information to help give you clinicians something to work with when you're making decisions.
One other question that has come up is, the real world application of scaffolds. Obviously, we discussed using them in the more proximal 2/3 of the tibials, but calcification is a very frequent problem in the tibial vessels. And so, Ramon, what are your thoughts about that? Would you use scaffolds, or do you have experience with using bioresorbable scaffolds in more calcified lesions, and maybe with adjunctive therapies such as lithotripsy or atherectomy?
Yeah, I think you make a good point, Ehrin, and what you're alluding to there is some of the limitations with any randomized clinical trial such as this one, that you have to put in place fairly tight inclusion and exclusion criteria, and therefore it may not be appropriate to apply the results to every single lesion you encounter in the real world practice. What we're trying to work on now is taking the data from LIFE-BTK and applying it to a more real world algorithm, such as for patients with heavy calcification or patients with bifurcation disease, long length disease or dissections, and how we best apply it. But there are certainly still a lot of questions that remain unanswered. In my own practice, having been lucky enough to be involved in some of the early stages of bioresorbable scaffolds for a little over 10 years now, I commonly get this question, can you use it in heavily calcified arteries? And while we don't yet know, we do know a couple of things. One is that the mechanical properties of the PLLA scaffold are similar in terms of radial strength to metallic stent over the first 6 months. So it will give you the ability to overcome elastic recoil. But I get away from, I dissuade people from thinking this is a magic bullet. If you can't get a good angioplasty result, then the scaffold is not going to do it for you. It really is giving you that additional mechanical support and a drug delivery mechanism, but you have to be able to overcome the calcium in the first place, whether that be with atherectomy or specialty balloons.
So I got a follow-up question then to Ramon on what you just said. There was a question from the group asking about lithotripsy. Often atherectomy has been associated with embolization in the tibial vessels, but not lithotripsy. So do you think that that's an option for prepping the vessel prior to placing the scaffold?
I think that's actually one of the specialty devices that best lends itself to use in an adjunctive setting right next door to a scaffold, because if you think about the mechanism of lithotripsy, it does provide a low pressure dilatation through the use of the lithotripsy mechanism, and if you can get that expanded, then I think a scaffold delivered in that position would work really well. Unlike DCBs, which have to push the drug into the wall and often are limited by calcium, the scaffold elutes it from the bioresorbable polymer on top of the PLLA backbone. So it should still get a good anti-proliferative result. And whilst it's yet to be tested, I'm looking forward to using it in association with lithotripsy.
Yeah, this is from again the Q&A. In the group, the DRS arm, you guys, it was dual antiplatelets for a year, right? And for the PTA, it was just for a month. Do you think that there's any change in this? Would you recommend then dual antiplatelets for a year after placing scaffold? I mean, it's going to be resorbed. Is there a period of time where you stop dual antiplatelets?
So Niten, even though it was recommended to have DAPT for a year in the DRS arm and a month in the PTA arm, it turned out that in the end, patients were on DAPT almost identically in both groups, and about 3/4 of the patients were on DAPT at the end of 12 months. So I think some of those perceptions are long held by our interventional colleagues, and there was a lot of clinical practice variation, I think, that dictated how DAPT was parsed out for these patients. I think as the guidelines evolve and as dual pathway inhibition with DOACs and antiplatelet therapy is brought into the guidelines, there may be some changes on how these patients are managed. But I think right now we didn't see any meaningful bleeding hazard, which is, I think, one of the important questions about using dual antiplatelet therapy. And after 12 months, we think that single antiplatelet therapy would be appropriate. And those data will be coming in, obviously, as we continue to observe these patients out to 5 years.
So Sahil, it's still 1 year is a recommendation.
That is what we recommend in the trial.
Yeah.
That's what we recommend in the trial, and I suspect going forward, that's what we would recommend, unless we learn something otherwise in subsequent studies. But right now, that is the recommendation.
Then another question that came in is regarding some of the endpoints, both of this study and of other studies in CLTI. And a differential approach that it's being used in some other studies is the use of hierarchical endpoints or a win ratio. I'm curious, Misti, I'm sure you have experience with this and others. What are your thoughts about that as an endpoint? Is there an advantage, or does it kind of depend on the device?
Our medical officer actually is very interested in these endpoints, mainly because you can have a hierarchy of what may be most important to the clinician, the patient, but still capture all of these endpoints. We're willing to discuss with any of the companies. We don't disapprove a clinical trial based on the endpoints. It's really up to the company to come to us, provide rationale, and we strive to keep things consistent. But again, we don't disapprove based on an endpoint. But we've been interested in some of these new endpoints based on the lessons learned from previous trials. So we're open to it. And I'd be interested in the other panelists' opinion on how they may interpret these hierarchical endpoints.
Any other thoughts from the panel?
I usually pick on Ramon for these questions.
Yeah, I think it shows how complicated some of the hierarchical analysis is.
Yeah, I think that's true. I think certainly it's easier to look at kind of a binary type outcome, but I think the potential utility of a hierarchical endpoint, I think, as Misti was pointing out, is you can prioritize what may be the most patient-centered result of an outcome, such as putting major amputation at the top of that hierarchical list, and then having other measures that are maybe less clinically significant but still biologically important lower down on the hierarchy. So I think it does emphasize that there's a lot to learn still, I think, from trial design and as we move forward in the CLTI space. Niten, do you have any other questions from the audience?
No, I think just a real quick answer from the panel, just saying, how do you think this is going to affect your practice? And I think we could start with Dr. Genovese and then go around the group. And from Dr. Malone, maybe just say, how do you think this is going to affect future trials? Just real quick, because I guess we're getting out of time. But start with Liz.
I don't know, as I think has been pointed out, these are a little bit of shorter lesions, maybe not generally applicable to our entire CLTI patient population, but I think this is promising technology, and I'm interested to see how some more studies come about. But I'm excited that this is potentially something that's going to be available to us to decrease recoil and potentially, improve some patient outcomes. But I think that more data is needed, but a very promising type of technology.
Dr. Razavi?
Yeah, the way we use we plan on using once it becomes available is spot stenting or spot scaffolding. The lesions are usually long, but the recoil or dissection is not typically long. It is to support those areas that fail within the intervened upon segment. So we anticipate that currently in our practice, about half the patients get drug-eluting stents in below-the-knee interventions. And not the vessels, but patients. And we anticipate that we would be on label and switching to this technology.
And Dr. Malone, anything else from the FDA side as far as affecting future trials based on this success of this one?
We've been interested in what we've learned from both the previous trials and this trials and how it impact both trial design going forward and also the devices that we may see as technology improves, as clinicians figure out which patients are best, which treatments are best in each of their patients. So we're excited about the innovation. We get excited with the companies when we see a new device and discuss the device evaluation strategy. And so we're open to working with companies, and please feel free to speak with us about any testing strategy, endpoints, clinical trial design. We are as excited as you are, so we're looking forward to it.
That's fantastic. I think we can leave the trialists out of it. We think we know it's probably changed your practice.
Fair enough.
Can I just
Well,
say that over the last 10
Go ahead,
years,
Ramon, go ahead.
using this device and the predicate device, there are some things in your clinical practice, you use them and you see them work, and you don't need a trial to know that this device works. But it's lovely to see the results of LIFE-BTK. I can foresee a future whereby we can be treating real-world disease with Scaffold. And by that, I mean long disease segments and calcified disease segments. And I think it's only just a matter of time.
great. Well, that really fantastic discussion. I want to thank everyone on the panel and also everyone in the audience for joining us tonight. Hopefully people found these discussions useful as we continue to learn from these trial results and their impact both on clinical practice and future research. As a reminder, attendees will receive an email tomorrow with instructions to claim CME. I want to thank everyone again on the panel, and everyone have a good night.